focusing. There are tense moments, and plus there are many add-ons. A more comprehensive review of the patient, what are the management plans, what are the strategies being discussed, and as we prepared for this and felt who would be the appropriate person, I actually found who I think is the best person on the planet Earth for this role, and that is Dr. Greg Stone. So my introduction stops here. Again, the purpose here today is for all of us to learn the role of the third operator, and so that the session can be kept interactive. Dr. Stone has at the moment an iPad which we have been trying to position in different places. There will be some mock questions coming to him. The final model is going to be that there would be a screen next to the hemodynamic screen where the third operator will be able to watch the question. So with that introduction, here is our simulation for Medflex Live. I hope not only will you enjoy the case, but that it will help you prepare for starting the pilot phase. Thank you, everybody. And Samin, Anu, and Greg, good morning. Your roles are all clear. Let's enjoy this wonderful teaching case and first live simulation for Medflex Live. And I'm going to sign off here, and good luck to you all.
Interesting case today. I think this is going to be kind of a classic case that we'll do for Medflex, and I couldn't have better operators here with Dr. Anu Kinney and Dr. Samin Sharma, who will be the first and second operators on the case, and they're going to introduce the patient to you.
All right, clearly that's the new journey of the Medflex, and we are making this test case to see all roles and how reasonably complex, not very complex case will be done, most important from various teaching point of view. And as we have done together, myself and my associate, Dr. Anpurna Kini, Anu, will be doing this case. And we start with the presentation of this particular case, which is case number 1, although it should be maybe case number 0. If we can show the slide of Medflex Live. And first operator, second operator, and third operator, so some names may change subsequently. So this is case 72-year-old. Patient was pre-op for knee surgery. Had mild angina, and they did a coronary CTA, which was positive for multivessel disease and high calcium score of 614. As we know, anything more than 400 by our guidelines considered as a high-risk scan. A patient does have a history of hypertension and hyperlipidemia as minimal symptoms, so SAQ is quite high, which is 87. He smoked long time ago. And cardiac cath done on February 8th revealed 3-vessel disease with syntax score of 20 and normal LV function. Patient is on good medication of aspirin, beta blocker, amlodipine, valsartan, rosuvastatin, and hydrochlorothiazide. So on February 8th, the tightest lesion was of the circumflex, 90+%, 95% OM. We put a stent. Then the RCA we took care, and today patient is here for LAD diagonal. So Anu, show it.
So RCA, you can see here, stent is patent. EF is normal.
Yeah, and I think for future cases, it would be great to see the previous films, to see the diagnostic, yes, and then see what was done before. But this is an interesting case because this is a patient with triple vessel disease who had mild angina and pretty much came to presentation because of the need for a knee replacement. And we see this all the time, right? How do you work up patients for possible coronary disease, and do you intervene, do you revascularize before a surgical procedure? So what are both of your feelings about that?
So I mean, clearly knowing that this limitation in this particular patient, and that is actually happening nowadays, many patients with some symptoms getting the coronary CT and coming to the table.
Right.
Is skipping the stress test.
Yeah.
And now after the ischemia trial, actually the number even of getting a stress test before coming to the lab have significantly declined. They're relying on the CAT scan. And good news is many of the places, they do the FFR, CT FFR, so that already those patients have been screened. And as you know, the new guidelines now is that if you have CT FFR, the Medicare actually does not reimburse for the invasive FFR.
Right.
You take that number because it has been shown to be
Right.
very reliable. So in this particular case, no FFR was done. But since patient came and has a multivessel disease and one lesion was very significant, we felt that this patient
Right.
will not be cleared, even in absence of the stress test, that we need to revascularize. And that is where we want to do today for the
Right.
LAD diagonal, which is, since it's not a 90+% lesion, and knowing the FAME trial and shown once you are 90%, your FFR is always almost 96% positive. In this particular case, with that lesion in the LAD and diagonal, we will make a decision of revascularization based on the physiological testing.
Great. So to close the revascularization discussion, other than the fact that his patient needs a knee replacement, he would have fit the ischemia trial. Mild angina, a definite coronary artery disease, and we know that revascularization is not going to prolong his survival, at least not in about a 5-year time frame. There's a risk of procedural MIs, but it will reduce his later risk of spontaneous myocardial infarctions, and his quality of life will be somewhat better. So we don't know for sure that revascularizing before a surgical procedure prevents peri-procedural complications. In fact, studies have been negative in that regard. But the reality is there does not seem to be any harm from the ischemia trial, and many surgeons still will not clear a patient until he is or she is revascularized. So you've done
And that is a very important point,
Right.
because many times, even we clear,
Yeah.
anesthesia
Right.
cancels it.
That's right.
They say, oh, 90%, we are not taking this
Right.
patient. And patient comes back after this. And that until there is a clear-cut evidence, you say, no, this patient is otherwise very stable, you
Right.
can go ahead and so. So with that note, you're right. I mean, there is no data to show that really revascularization
Right.
could decrease your events after non-cardiac surgery versus just a
Right.
medical therapy, but that is like practice, and particularly these kind of extensive disease. Common practice is to revascularize before
Right.
whether surgical or percutaneous. In this particular case, non-diabetic, low syntax score. So by our
Right.
criteria, we have the criteria: patients with the high syntax score, multivessel disease, and diabetic with the syntax score about 22, and left main 32 and above.
Yeah.
They get a surgical consultation. So this patient, particular
Right.
patient, because of syntax score of 20,
Yeah.
we just went ahead and felt that PCI is appropriate in this case.
Sure. And so you treated the severe lesions in the right corner in the circ, and now we're left with this mid-LAD bifurcation. And I think you're doing the right thing here. I mean, we're still revascularizing to relieve ischemia at this point. Maybe in the future we should be treating anatomic disease, but we're still deferring anatomic disease that's not physiologically significant on the basis
Go
of
to the same
FAME,
view.
FAME2, and other studies. So to me, this lesion looks about 70% stenotic, but this is a typical case. Some people are going to look at this and say it's 80 or 85%. Other people are going to look at it and say it's 50%. And so I think you're taking all the guesswork out of this by doing a physiologic test.
Are you there?
I think you could approach this either with FFR or IFR. We've talked here that FFR is going to be used in this case just because that, Sinai does, thousands of these cases, and we're very, very comfortable for many years doing FFR. So they've maintained FFR for many of the routine cases. IFR has some advantages when there's, multi-segment disease and you want to do a pullback and you can really learn where the contributor of the disease is. But this is a nice focal lesion, and I think FFR is going to give you all the answer here.
Okay. So clearly these wires are not as torqueable as our regular wires. So
Right.
Still making little curve, and may need to make because we still have to equalize once into the vessel. I don't think we are
Some
there
dye?
yet. You want to go to caudal view? Will die.
Yeah, it's a little hard in this AP cranial view to
Yeah.
Want to go caudal?
exactly
Okay.
see the origin of the LAD.
Yes.
So now you come into a caudal. That makes a lot
So
of
it's a
sense.
7 French guide, knowing that if positive, knowing that even if there is only diagonal positive, good, you go back. Okay. Equalize first.
So let's go back to the view.
Not
Not yet,
yet.
not yet. Equalize.
Yeah.
Okay.
Yeah, that's okay. Yep.
You're able to see the angiogram. So I think like Greg mentioned, at the level mid-LAD is moderate lesion, 60-70, but you see the diagonal takeoff angulated with a 90% ostium.
Right. So that will be,
It's a
if the
very
FFR is
complex,
significant, then we'll talk about how to treat the bifurcation. And if the FFR is not significant, we can also talk about should you then assess FFR in the diagonal lesion.
Okay.
But the LAD is more likely to be physiologically significant for any given severity stenosis and lesion length than in the other vessels because of the larger amount of myocardium it subtends. So I suspect this is going to have a positive FFR, but we will see.
And the key is that when the whole issue about the one stent versus two stent controversy, I think controversy should be that you identify the case where you need an additional stent in the side branch. So that case, you should go with a two stent approach to begin with. Now, in this case, because of angulation of the diagonal, you saw the superior uptake of the diagonal. And if you try to do any stent after as a bailout, will be even more trouble. Later on will be more difficult.
Yeah, and you can see, as was mentioned, these wires still are not as torqueable and not as forgiving as
this is diag. We're going into
standard workhorse guide wires.
Yeah.
Yeah, many times if there is a trouble, put another wire side by side and use as a buddy wire.
Okay.
Exactly.
Yeah.
Of course, in extreme cases, you can use a microcatheter, but there's...
And again, same with the micro, the point is there is still, we don't have, good.
Nice.
Very good.
Okay.
We don't have the,
okay.
Go more. Okay, start the drug, please.
Okay.
Yeah.
So what's our...
Resting is 0.88.
Okay, so resting PDPA is 0.88. It's really unusual if the resting is 0.95 or above to get a positive FFR. It's not impossible, but it's unusual.
Good.
And of course, everything was equalized and balanced at the beginning. It'll be important at the end to pull back the wire and make sure there was no drift.
And of course, always explain the patient going to feel once you start.
Right.
Yeah.
And you're giving the adenosine intravenously.
140. Yeah, intravenously.
140 mics per minute.
microgram per.
This patient has a central line, so.
Okay, as a central line.
I mean,
I still like giving
vein.
it. I still like giving it IV. I mean, some people do boluses, and I think if the bolus is positive, then you know it's positive. If the bolus is negative, you just never are 100% sure. So I like IV. Okay, and the patient's got a kind of a slowish resting heart rate, so it'll be interesting to see what kind of chronotropic response he gets from the adenosine. We'll keep an eye on that. Of course, the half-life is in the order of a half of a second.
And always see that wire is always distal, because remember, if you leave it in the middle segment.
Right. And there does look like there is somewhat of a myocardial bridge in the mid-LAD. There's some bridging, some systolic squeezing.
Okay, stop it.
Here we go.
No, wait.
No, but we don't go further.
Now we can stop.
Okay, let's pull back now. And we are doing the pullback. We went down to 0.72.
So that's important.
Which was expected. Yeah.
Notice they stopped the adenosine as soon as it became clearly positive. There was no reason to see if it goes down to 0.5 or 0.4.
No.
And now you can see the wires pulling back, and you want to see that when you get close to the guide that it goes up to, anywhere from 0.98 to 1.02,
which is good,
is acceptable.
Okay.
And there you go. It's 1.01. Okay. So perfect. All right. So clearly a physiologically significant lesion. So we now don't have to worry about the diag, because the diag you're going to have to manage.
Good.
So now really the discussion is, okay, how do you treat this mid-LAD bifurcation lesion? And I think you heard Samin talk a little about this. I think a lot of people would treat this provisionally. That is, wire both branches, not dilate the diagonal, but treat the LAD, and then see at the end if you need to rewire the diagonal, and then do a KISS or even a bailout stent. But I think the consideration here is that it's a very shallow angle. You look in this view, and there were several other setup views. It's like, less than a 30-degree angle. And so there is concerns about accessing this diagonal and an increased risk of it closing because of that shallow angle. So even though it's a focal osteal lesion, the thought here is to do a minicrush technique and make sure that the origin of the diagonal is preserved. And I think that's very reasonable. We talk too much. We sometimes fight. We argue obsessively about a one stent versus two stent technique. And I think with good technique, in my opinion, particularly if you do image guidance, but with good technique, high pressure inflations, a
We're in a
pot,
small branch.
and in most cases a final kiss, that you will get similar long-term outcomes, perhaps even better, by stenting that ostium. But there's no reason to overdo it. You don't need to put a huge long stent in that diagonal. It's obviously a very short lesion. Often a 13 millimeter stent, 8 is too short, but a 13 millimeter stent is probably all, 12 or 13 is all it'll take.
Oh, we are in the diag.
Okay, well, that's okay.
That's fine.
You can take
I'll
it.
leave it that. But the
Sure.
you want to leave
Put
it
a
there.
second wire.
Okay, that was the hard one to wire.
Yeah.
Okay,
Let's go.
so
Yeah. So hard, and so
Never-
key that you have to put a wire both, and actually ideally you wire the most difficult vessel first,
right.
because if you put a simple and then you put a difficult wire spinning,
Exactly.
so much wire,
so they can wrap around
Yeah,
each
wrap around.
other, and
it's a good.
so never
when-
look lady luck in the mouth or something like that.
Get guys quicker.
Okay,
What is
so
going
what
on?
are
What's
what are
going
your workhorse wires?
So for the main vessel, we like to use
keep
run
going.
through. That's our workhorse wire.
Okay, run
And,
through.
Yeah, that's what I had first, thinking we'll go into the LED. Now going back to the diagonal or the side branch, this is always the question people ask, what's the wire that you like, especially if
other
you're doing a
stents we did?
provisional. We all are like a polymer jacketed wire to go
Okay.
into the
318.
So is
side
that what
branch.
you have here now? that you
This
can
is a
use for the
fielder.
other-
So this is
2.5.
already opened, so we'll go to the main vessel with the fielder.
Okay.
Easier to get into the side branch.
And
So always there's a discussion, do we leave this wire,
Right.
jail the wire, not jail the wire,
Oh, yeah,
But we always like to leave a polymer jacketed wire, very easy to jail and even to remove it once if it's behind the stent.
Yeah, I think you'll never be sorry about jailing a wire.
That's it.
I really believe that. I've seen
Diagonal
too many
cutting on.
cases.
No.
I actually had one in the
Leading
early
up
stage of my career where I said, okay, I don't need to jail the wire, and then a moderate sized diagonal went down and I could not rewire it. So I think, having that jailed wire shows you the origin of the side branch, and it actually will facilitate a little bit of flow in the side branch. It gives you a target to go after. So I think it's very prudent. I've never had a trouble getting a quote jailed wire out.
Yep. And so what we do is, knowing that the tight lesion is at level of the bifurcation and at the diagonal, we have 2.5 cutting balloon. Although people can use just a high pressure,
Right.
we use just more of a plaque modification balloon. This is the our Wolverine 2.5. And this will cut
Right.
both ostium and the proximal part of the LED. Question is, do we need to modify LED further, or we just put then 2 stents?
Yeah.
And the plan is put a 2.512 in the side branch and 3018 in the
Oh.
LED. Or the 2.75 in the, no, 3018.
Now you're doing this without image guidance.
Oh.
And then in the end, we can get our IVUS ready to complete, to see your stent position, and all those things have happened good.
Yeah, it's always great. So you know that, and here, of course, with a bifurcation, you always have a tapering vessel. So I suspect that proximal AD is at least 3.5.
Yeah.
The middle AD is 3.0, but I think you want to do a 3.5 pot.
Go.
Okay.
I think we'll be okay. You want to do the same balloon for the LED? Huh? I don't think we need a different balloon. I think we're going to need a balloon later.
Yeah, I think it's fine. It's
I think we can go
a
direct
short
now.
focal
Yeah.
lesion.
Yeah.
Yeah. Because non-calcified angiographically,
Exactly.
Okay. What was the stent used on the other side?
Zions. So we are ready now. 2.512 for the diagonal and 3018
Okay.
for the LED, right?
Yeah.
Good. Okay. Give us now the same side branch stent first. More difficult one,
Yeah.
2.512.
So here they're doing a mini crush technique as opposed to a DK crush technique. I think when the side branch lesion is simple like this, a mini crush is fine. I
Can
personally
get a
like
main
the
vessel.
DK crush for more complex lesions. And you'll note they used a 7 French guide, and so they're going to put in both stents simultaneously. If you wanted to use a 6 French guide, or if you wanted to do this radial, then you could put a stent in the side branch and a balloon to crush the side branch stent, and then go back in with the main vessel stent.
And that's the mini crush. That's why once we are working with the radial, in this kind of case, majority will do a mini crush.
Right.
When do a femoral, go with the regular way. The DK crush again. I'm sorry, the radial will do a more of the DK crush and the femoral mini crush because it requires 7 French.
There's also step
Right.
crush where you can do, where you will go the same
right.
way.
You can do it either way.
Yeah.
Just with a, instead of 2 stents through the 6, you just use 1 balloon in the main vessel and a stent in the side branch.
So same thing, every lab is different.
Right.
Majority of cases we do with a mini crush at Sinai. So some cases, of course, with a DK crush, but again, everyone different. We rarely do a culotte, and majority of this is the 2.5, 12 Zion's sky point going into the diagonal.
And one of the things we are going to talk about in Medflix, we are going to name the wires we use. We're going to name the devices that we use. We'll talk about why those particular wires and devices are being used. We're not going to be, ashamed or scared to mention that, because people have to make decisions, and there are differences between devices. When we don't think there's a major difference, we'll mention that too. So I think that you could probably use pretty much any stent you want. In this case, this is not a complex case, and I think for this size vessel, most of the leading manufacturers make excellent stents that would have very similar long-term outcomes, whether it's a durable polymer or bioabsorbable polymer.
And then what we try to do is, patient with a multivessel, when they come back for the stage intervention, we try to use the same stent brand. Reason is because then they come in the same follow-up point of view, is in the same category, so not a mix and match. Okay. Okay, right picture?
Okay.
One of you guys
some
come.
Some die.
Good, little die. I think
Good, right? Yeah.
Okay, I'm deploying the diagonal now.
So you'll notice this is a mini crush. You'll notice that the diagonal stent proximally is just a few millimeters into the LAD.
16.
And it's covered by the length proximally of the LAD stent. And that's a 3.0 stent. I think that's too small for the
LAD is
proximal
a 3.0,
segment. But it's, I think, probably going to be perfect. Maybe the mid's going to be 3.25. We'll see what the IVUS shows. But
we can do OCT,
I think with the proximal optimization technique
OCT.
with the 3.5.
Let's open the OCT and call Kiski.
It'll be beautiful.
Some die.
Now the wire out, again, majority of people will remove the wire of the side branch with the mini crush stent.
I think with that you do remove the wire. Usually you'll do a puff first to make sure that it's patent, of course, and there's no distal dissection. But here, when you've got 3 overlapping layers of metal in a mini crush, it's still probably prudent to remove the jailed wire. Although it's such a short overlap, you're probably fine if you don't too.
Okay, done.
Okay.
So 3.0, 18, 2.5, 12 have been deployed with our standard mini crush technique.
Okay.
And we are going to take both the balloons out. The wire of the diagonal is still in the guide.
Okay.
The LED wire is still across. And we take a picture and then we decide.
Let me see if I can swap and recross it.
Yeah.
Okay.
I want the fielder to recross into the diag. Okay.
So Dr. Kinney, do you routinely try to do a kissing balloon inflation?
Yes, after the routine. Recross.
Yeah, and I think that's standard to try to do. This can be the most difficult part of the case, of course. But again, with a mini crush, it's much easier to cross the side branch.
2.012 compliant and 3.25 12 high pressure.
So
you want to take a picture? Just
you can see the technique here is that she's trying to use the same wire that was in the LAD because she knows that that's across the stent. And so that's beautiful technique. So you don't pull out proximal to the proximal portion of the stent. So you know you're in the true lumen. And it was quite easy to cross despite the fact that that's a beat up wire. So that's in a little branch. You know, Dr. Kinney may want to either pull it back a little bit or get it into a larger branch of the diagonal. You know, we have relatively few major complications in PCI today. You know, one of the most common still is these micro perforations, either macro perforations at the stent site or micro perforations from, distal wire drift.
Again, I think we're going
which
to
is
the
very
small
easy
branch, right?
lose track of where the distal wire is.
Good. Going back.
Okay. So again, a caudal, that's nice, beautiful technique. Again, that loop helps you be confident that you are intraluminal.
Good. Let's open the ostial diagonal now. The first question always comes.
Some people, you could have done a pot before you pulled the wire to go into the diagonal, and that would have made it a little less likely that you would have gone behind the stent struts.
Yep. So now, if you have a other used balloon and non-compliant may give a little trouble. So we always will say in the minicrush that go with the small balloon first. So we have 2012 compliant.
Yeah.
And then finally, of course, you do a case based on this particular vessel, and they're going to get ready with the sizing point of view.
And I think that's really safe. I mean, you could try to cross the side branch with a 2.5 non-compliant balloon straight, but half the time you won't be able to. And
even
so,
this 2.0 is giving a trouble here.
Yeah, I would sometimes, and this is compliant, right?
Yep. This is
I would sometimes start with a 1.5 compliant, take it up to high pressure, and then usually the non-compliant would go. But yeah, and again.
Good.
You want to do, no, you can
sometimes
do
the pot will also make this easier as well. So I like doing the pot before pulling the LED wire.
You want to do the thing?
The other balloon?
No,
Two
anchor,
things.
anchor.
Now that's what I'm saying. You can do an anchor into the LED because we have to dilate LED also.
Yeah, but you can't do it with that size balloon. It's a length. Remember, it's a short. What's the length you have?
12.
3.0?
Yeah. 3 to 5.
Okay, so with a 2.0 compliant balloon.
Okay, give me.
You know, a little surprising, but not that surprising. Difficulty crossing into the diagonal.
So maybe we can make a principle. If it's a 2.5 side branch, go with the 1.5. It's a bigger one, then go with the 2.0.
There's lots of tricks to help here. Again, as you mentioned, a 1.5 balloon. Sometimes short works better, but sometimes actually long works better. I also find that sometimes, you know, usually a daughter technique is good, but sometimes actually just rifling it across the lumen. There you go.
Okay.
All right, so here's.
Don't go too high.
So this
outside.
is an LED balloon. So you're putting in an anchor balloon. So this is to give better guide support. So it's an anchor balloon in the LED.
The wire has gone through probably.
Yeah.
Okay.
Okay. Deflate. Looks good.
Okay.
I want to recross into a different. But now the LED balloon has to come out.
Let's take it out first.
Okay.
So key is that we are now going to go through the different strut of the diagonal.
Right.
Knowing that whatever we did, it was not giving so much trouble. Otherwise, we can go down to a
1.25.
Yeah. Good. Okay. Go back again now.
You know, everybody emphasizes the situations where it's important to try to go in the proximal portion of the strut or the distal portion of the strut, like here. But the reality is, you know, often the strut is off to one side of the orifice of the side branch, and the wire is going to go where the wire is going to go.
1.2 balloon?
If you really want to see, you could do an OCT, and the OCT will show you where the strut is, and it'll show you which orifice you're in. Okay.
1.2 balloon.
Okay.
You want to just dilate with this balloon at the level? Same, like a little, although not truly pot, but.
Yeah, I mean, it looks like you've got pretty good guide support.
Yep. Okay.
But you've got an anchor balloon. Sometimes you can use a guide extension. Sometimes it takes a stiffer wire. There's all sorts of tricks. And again, the pot will often help. Was that?
That's why we are doing a little.
Was that a 3.5 or?
Yeah, 3.25.
3.25.
Yeah,
okay.
because the last picture was very good play.
Okay, so the pot will change the orientation of the struts into the side branch.
Leave it there. Go. Let's go with the 1 point.
And you know, when you also can't cross, you also always have to worry whether you're in the true lumen or whether you're behind the
1.25 balloon. No, this is 1.2.
But here we know Well, originally we knew
Sprinter
that,
legend.
that
Don't give
Dr.
me a-
Kinney was not outside the struts
Yep.
because she never pulled the wire back from
Exactly.
the LAD. But now this is a new wire. So we just have to keep in mind that that's always a possibility. I think unlikely, but always a possibility.
Now we are going with a small one.
Okay, so this is a 1.25,
1.2, yeah.
Yeah, 1.2.
1.20.
Sprinter legend.
Yeah.
I
If
said
anybody want to ask question, they can ask the question in the
Okay.
chat box.
All right.
Yeah.
Okay, so we now have some questions from the audience.
What do you want?
So
Sprinter legend balloon.
um,
Also, I would never.
Jacob
do
Bigelow
Zions.
asks, what
Zions, I've had
anticoagulant
so
is
many
being
times
used?
Problems.
Okay, that's
Recross
question
and
number
kiss and all
one.
these
So you're using standard unfractionated heparin or bivalirudin or any other?
Yeah. In this case, is the bivalirudin.
Okay,
And
so
keeping-
bivalirudin, which I still like as a choice from the femoral
What about
artery because the
antiplatelet
bleeding
therapy?
is
This patient is on?
definitely less by about 40% less. What did you do? The patient's already on aspirin and clopidogrel coming into the case.
Yes, got
the
loading
patient-
dose.
Patient got, was on aspirin and clopidogrel from the earlier procedure and had previously been loaded. And the question is, why not do this case from the radial?
Yeah. So I mean, again, the radial people, anytime bifurcation when two-stent approach,
Right.
knowing that we do more minicrush, so we prefer femoral. But if there is an issue or patient's
Right.
special preference, then we'll go with the radial.
Yeah.
But yes, this case definitely could be done. It's
Yeah.
not a super complex where you worry about anything else. So I think this is the case could be done either. A few of my
Get Corsair.
associates.
Corsair.
But it is interesting that, I mean, you see the struggle to cross this side
yeah,
branch,
right.
and that would be magnified with the
With the
radial
radial,
approach.
exactly.
You never get good support, almost never.
What do you want now? You want to no?
Okay.
Anchor again. Anchor
I
again.
mean, that's what I'm doing.
And then the question is, what about just a DCB for the side branch? And I can answer that. I mean, that might be a reasonable strategy, but of course we don't have that available in the United States for coronary use. And we really need to, I think, get some better data
Okay, good. Go.
for DCB use, both
Go.
in the native coronaries and for, as de novo lesions, as well as bifurcations of a side branch in
So-
conjunction with a drug-eluting stent.
So the anchor technique worked second time.
Okay.
So now we have so this balloon is a 1.25 Sprinter legend.
Okay.
Earlier we tried 1.2, which was 8 millimeter balloon.
Yeah.
This is a 6 millimeter balloon.
Okay.
So even 2 millimeter shorter
Shorter.
length helped.
And 1, 2. And sometimes, interestingly, a longer balloon works
What do you
better
want?
than a shorter balloon
Advance the
to
ladies
cross a
and
side branch, which is interesting.
Case here.
But here with a
Okay. Pull back again.
the
I
anchor
go-
balloon
Yep.
and the 1.6
1.6
millimeter.
Yeah, 1.256 millimeter. It's a
Okay.
Sprinter legend balloon.
Okay.
We have to figure out which company makes it.
1.25 Sprinter
Medtronic.
Legend.
Medtronic, right?
Yep. Medtronic.
Okay. So that was
Go
the
up here.
key here.
Go
And
up
this
here.
again, if you're going to do a lot of crush technique, this is the most complicated part of the whole procedure. Sometimes rewiring the side branch can
Go
be
up here
difficult,
again. Very high.
and crossing can be quite difficult. So I like the routine use of a small compliant balloon first, and then you go to the full-size non-compliant
now
balloon for the side
2O
branch.
balloon.
So this is the 1 point. Now we are going back with the 2O.
So now you're going to go to the 2.0 compliant just because
Because
it
we
was
already
so
had it, yeah.
difficult. It's already open, so let's just make sure.
Yeah.
And I think that's a good idea.
So what I had called for that if this technique was not working was get a Corsair ready.
I'm sorry, say that again?
Corsair.
A Corsair.
So we can use a
Yes.
Corsair and go
Yeah.
to the side branch through the.
So this is what in the Bifurcate 3D app, which Dr. Keeney made. So that is actually goes through
Yeah.
various steps of uncrossable. So one of them
Right.
is when you have trouble, you can always think about going with the Corsair. Corsair really goes through, and we do use
Yeah.
it time when there is nothing is going. So just make a little lumen. Rare cases you want to go with the even laser, although laser usually acutely we are not done, but we have done many uncrossable side branches when patient came back using the laser. Very rarely done rotablation, but key is in this particular case, the Corsair helps quite a bit when your wire goes in.
Okay.
And nothing
see,
else is
now
going.
now it went.
Okay, so notice that the 2.0 now goes quite easily now that you made the channel.
LED
Why?
also?
with the
Oh,
1.25.
you want to go 2.5?
No, we'll be okay.
Okay, good.
Yeah.
That's fine. OCT is ready, Kiski? Okay, good. Have it ready.
Okay.
Yeah.
So once they've done the crush and
Yeah.
the final pot, then they're going to OCT the main
Good.
vessel.
Yeah. So we'll just do the kissing balloon. I know a lot of people say pot, repot, and kissing. So
Yeah.
are we inside? Floor?
Good one.
So
Okay.
within it.
So that is the
don't know.
3.0 and the
3.25.
okay.
3.5 and 2.5 and 2.0. So I
Okay.
think looks good.
Go
dial
up
it here more?
Go up here, yeah.
So
No, not-
3.5 and 2.0.
Go up.
Okay. Are you going to go 2.5 in the side branch?
No, I think we're okay.
I think we'll be
Okay.
okay. Let's see.
Okay, down.
Well, we'll see. You may, the
Had
OCT
to
will
go.
be interesting. You can get a sense of the morphology of the side branch with the OCT. You can't with IVUS, but you can with OCT. And you may have a little bit of carina shift with only a 2.0 in the side branch.
Unless you have the lumen of the side branch, no?
Yeah.
We can see on the 3D if you can show it to us.
Right, exactly. You'll get a sense on the
I mean,
3D. And if you have any
The
questions,
software
you can
does
always
read
OCT the side branch.
Yeah. Okay, I took the wires out, okay? Side branch wire out. I'm just
Yep.
going to the main vessel.
And again, OCT has a lot of advantages here. It's the most accurate dimensional measurement, more accurate than IVUS, which tends to overestimate lumen sizes and dimensions. And it will show you, again, very nicely the bifurcation orifice, where you don't get nearly that level of resolution with intravascular ultrasound. This patient has nearly normal renal function, so the extra dye is not an issue.
Good. Proximal
Wow.
looks negative.
So the distal,
Right, so
remember
there
our
you can
balloon
see
could
the,
cost something.
Huh?
The snake that
Distal
ate the
edge,
mouse,
the
right?
balloon.
That's what we said we always wanted.
2.325.
Same balloon we can do a little bit.
So you might want to give a little nitro. There
Yep.
could be a little bit of proximal
Spasm, yeah.
spasm.
Proximal, more so distally.
Right.
You want to put a low pressure there?
Yeah.
Yeah, that's fine.
No.
What?
Please, get a new one, 3.0. The 325 cost
Yeah.
you.
Okay, 3.0. Get a 3.0 balloon. 12. 12 will be okay. Yep. So now actually, you know what we did? If we can go back to the slide, usually we started showing the angiogram and went directly into the case.
Right.
So basically our always has been that complete the case presentation with appropriate use criteria. So this is the case which we plan was FFR-guided stage PCI of the LED diagonal bifurcation using dedicated 2-stent mini crush technique. And based on the OC criteria of 2017, this patient is a no proximal LED because it's a mid LED and the diagonal, and patient on dual anti-ischemic therapy. Although no stress test was done, but FFR less than 0.8. So will be appropriate by all the measures.
Absolutely. And it also shows you people, not all triple vessel disease is created equal, right?
Yep.
This triple vessel disease with a syntax score in the low range. So it's very appropriate to do PCI in this patient.
So how are you showing the OCT?
Did you give a little nitro?
Yeah,
we did
I did.
now.
I did.
Great.
We gave a lot.
So you'll notice that, it looked like there maybe was some distal spasm at the distal edge of the stent. We got to look at that. And there's a little bit of an accordion effect
Yes.
in the distal LAD.
Go to the angio. Go to the fluoro again.
Okay.
SSR to go now.
Yeah, you could show us fluoro on the screen. Great. And now we're seeing the OCT. Okay.
Kiski, ready? Okay, tell me. Okay.
450.
Okay.
And 0.
So, a question from the audience. Dr.
Ready?
Samuel asked, what about the segment after the stent in the diagonal? Will you treat it?
Yes, good image.
Yeah, there
We'll
was a
take a look
little
again.
disease. There always a disease there.
Right.
The diagonal
Right.
further down.
You could-
So we thought that if we doesn't need anything, we leave it. One question concern right now is the LED portion after the stent, because that's where, we did a
Okay.
balloon anchor also. So it has not created
Okay.
any damage. We need to see it. Anyway, this
So there's no
OCT will tell us now.
I'll show from the
All right, so
visual.
this was interesting.
So,
Yeah, that's
So,
also
so
because
very
large
diseased
balloon.
artery.
so this is the distal edge of the stent.
Mm.
Okay.
Yeah, well
Go
expanded,
go
well-
distal, go distal.
much more distal.
Yeah, yeah.
Yeah.
Looks like this is the tight part.
So you can see there.
Like a little bit dissection, maybe the balloon or something.
With the dissection.
Yeah, there is a
Yeah.
dissection there.
Yeah.
That's
Understand.
Very focal like
They put a
lesion.
shorter stand, 3
Yeah.
Yeah.
But
Well,
yeah,
this
so I
is
think-
normal, but just this part is
3 or 12
like,
Zions.
Yeah, so I think you do want to treat that, and everyone always asks, how severe does the section have to be till you treat it? And there's no absolute rule, but my general rule is that if it's 90 degrees or more, and if
Put a
it's thick
stent there.
enough that if you think of removing the wire, could it occlude the lumen? Would the flap come over? Certainly if it's 180 degrees, but even more than 90 degrees, then I
Are
think
they
it's
ready
worth
in the
treating
room
because there's
or-
almost no downside.
Dr. Kinney,
And
Dr.
this is
Kinney,
one
sorry.
that's a very thick dissection. You can see it actually goes back deep into the media. And so I would put a stent there.
Yep. What about the
Let's see,
diagonal?
let's look- let's
see
look-
the rest of the
Yeah,
stent.
let's see the rest. So come back. So we'll measure that. So actually there was a little more calcium there than you thought, right? Okay.
And come to proximal,
No, don't
yeah,
open.
more expanded.
Yeah, so look how huge that vessel is proximally.
And actually, this is the proximal edge of
And
the
you've
stent.
got a bad dissection proximally.
Yes, right.
So I think you
18.
see that
Yep. With
so I
the
mean, you have a
proximal
bad dissection
Yeah, this
proximally.
is proximal edge of the stent has a like huge
Yeah,
dissection. so-
severe dissection. And actually, if you come back a little more proximal, look at, yeah.
Yeah, here's normal. Yeah,
So this
like-
is a diffusely diseased vessel. It's much more diffusely diseased than you'd expect, just angiographically. And this is why intravascular imaging takes all the guesswork out of that. You would not have suspected that proximally.
Yeah.
You might,
Distally, yes.
but not proximally. So this is going to take 2 more stents, 1 proximal and 1 distal. And can you measure proximal? Do you have a
Sure.
proximal reference? Can you measure the, it's at least 4.
Actually, diffuse lesion, even the proximal. So come to like most proximal part. This is, I can see the blanch. So
Okay.
after the blanch, so like here, I check the EL to EL, but not clear. But it looks like
It's not totally clear, yeah.
yeah, vessel size
Well, that's
is
a
like,
big chunk of calcium there, yeah.
yeah. And the lumen mean diameter is like 3.0.
Okay, and that, but that
Another
EL,
3.518.
what's that EL measurement?
EL is not clear, but it looks like 3.9.
4.0, yeah.
3.9.
Yeah,
Yeah. So here, so remember that lesion was always there in the proximal LAD
Right.
with a clear-cut eccentric calcium. So
exactly.
that lesion was always there. So now clearly by having this stent has created an edge.
That's right, right.
Dissection
That's
of the
where it
proximal.
always dissects, right? And
Yeah.
especially there, that was just, it's a very short focal chunk of calcium. You can see it on this OCT image. But it was enough
Yeah, here.
to create a
So
dissection.
we can see that here now. Calcium and that angiographically. So this definitely will be worrisome. Even without doing the imaging,
Yeah.
I'll be worried about this situation. So we'll put 2 stents.
Well, you know,
proximal
and again, in
distal.
my eye, it looked a little spasmodic,
Yeah.
but
But we get a lot of
you
nitro.
can
we
see that the
give some
lumen,
more.
right. You can see the lumen
Correct.
was narrower than at the beginning.
Yes.
And the OCT takes all the guesswork out of it. It shows you that you have proximal and distal dissections. And I think if you did not treat this, your risk of stent thrombosis would have been much higher.
Go on.
So, all right. So what's this size here?
This is a 3018.
3018.
distal?
So for 3018 distal.
Yep. Now what
Okay.
about the ostial of the diagonal? Negative.
The outside diagonal looked pretty good.
Yeah, pretty good. Yeah, looks
From what
fine.
we could
looks
see.
fine. Well
It
open.
looked good. That's one thing I think you don't have to worry about.
20.
And again with OCT you can evaluate the side branch ostium reasonably well. And you don't see any narrowing, which is great.
Here's a 3D bifurcation model. The ostium looks open.
Okay, let's see that. You're going to put in a 3.5 approximately,
3.5,
or
yeah.
3.75?
3.5. 3.5 need to be dilated, but what is the lumen is 3.0 right now,
Yes.
and vessel size is what?
3.9.
Yeah.
3.9. Okay.
So that's why I was saying, you might go up to a 3.75 non-compliant.
Okay.
As long as you stay, you know, like at
Within
least
it now.
0.25 less than the media, you're going to be fine, and you'll get maximal stent expansion. So if he's measuring 3.9, it's a little hard, you know, to see the
I think
EL.
3.75 high pressure balloon will be okay.
Yes, I think so too.
12.
And
yeah,
the
that'll be
stent,
okay.
several areas, the stent looked a little
that.
bit underexpanded.
Yep.
So we'll get one more OCT run when this is done.
Sure.
They'll die.
Yeah. I think you could be up to that. You could come up to that first branch.
Yeah.
I don't think you have to worry about covering it.
Good.
Okay.
Right. We are in. Good. Go.
All right. But this is such a brilliant demonstration about why, in my estimation, intravascular imaging reduces MACE by 35 to 40% in more than 10 randomized trials with drug-eluting stents. And it just, again, you can't appreciate all this angiographically, and it takes the guesswork out. I mean, rather than worrying about it and then worrying whether you're going to get that phone call a few hours later, you immediately see what's going on, and so you immediately treat it.
Okay, we are ready for the second OCT.
Okay. So you did the high pressure inflation?
Yeah, good. High pressure going now, and then
Okay.
I'm just saying, get ready. Yeah, talk to the patient. What's happening? Yeah, you just keep sleeping. I'll wake you up in a few minutes. So far, good.
Everything's going fine,
Go.
sir.
Yeah. Negative.
So, you know, you looked at this LAD initially and you think, okay, a reasonable focal stenosis, yeah, bifurcation, but that doesn't look too complex. But, you know, this patient had triple vessel disease, so you can be pretty confident there's plaque in almost all segments of his coronary arteries.
Okay.
All right.
Let's do it to see it to believe it.
All right.
Come.
And you see 2 extra stents took Samin, I think, about 5 minutes. So it's not a lot of work. So we have a question from MP, were the balloons used for the final kissing dilatation oversized, resulting in the dissection? And I don't think so. I think they were actually appropriately sized.
Actually, diagonal was undersized.
Yeah, I think that, exactly. I think the diagonal was undersized. You know, from Finnett's law, if you use the correctly sized balloon in the side branch and the main branch for the distal portion of the main branch, it will be appropriately sized for the cross-sectional area in the proximal branch. So I just think this was diffuse disease. And when you get edge dissections is when you put a stent in a disease segment.
Just a moment, please. Enabling.
All right, so we're now doing the,
Cine and inject.
okay, doing the OCT run.
Go.
Yes, great image.
Okay, a little bit of
Yeah,
blood
little
artifacts, but I think we'll
blood.
be able to see through it.
But we can assess. Just a moment, please.
Okay, let's see the distal edge first.
Sure.
Okay, so there we go. So there's the distal stent, a small amount of malapposition.
Okay, I'll start from the distal. Oh, it starts from the intrastent, but almost edge.
Okay,
And looks like distal edge looks expanded and all.
yeah, that's blood artifact. I don't
yeah.
see any dissection there.
Yeah, no dissection. Yeah.
And I think the stent
is
looks,
well expanded.
stent looks very well expanded
And-
distally.
Yeah, normal gap. This is the first bifurcation part.
Well,
Proximal dissection is also covered by the new stent.
that's beautiful.
Beautiful. Yeah.
And very well
Proximal.
expanded.
Well expanded.
That's
yeah.
Excellent,
Perfect.
excellent.
Proximal is perfect.
Can you get us a minimal stent area from
Sure.
the original lesion?
Sure.
You know,
So actually, this is super long stent. So
Right, but I would go, rather than going distally, just, the restenosis is likely to be where the big plaque burden was at the beginning, which was most severe at the bifurcation. So maybe you can go just distal, proximal to distal to the bifurcation, and tell us what the minimal
so
stent area is
first, the
there.
proximal of the MSA is like 6.7.
6.7, 6.8.
6.8
And
and go
just-
to the distal.
Just distal to the bifurcation?
This is like almost the start of the pullback. It shows like 3.5, but vessel itself is small. And
Right, yeah, I wouldn't go at the beginning. Just distal to the bifurcation.
Okay. This is the bifurcation.
Just a little there, right
yeah,
about
like
there.
here, like
yeah.
4.5 or something.
Okay.
Yeah.
Okay.
So let's take a last picture now. Go back to Sene, please.
But it looks well expanded.
Right,
I
yeah.
don't see much plaque behind there. So that's, you're limited by the constraints of the vessel size. So, and the most important thing is that, here you can see the wire's out. Angiographically, it looks brilliant. And, the diagonal is widely patent. You'll get a cranial for us.
Yep. And
I'm not worried about that distal edge of the diagonal stent. I think that's just a little kink.
Yeah.
But we'll see what the cranial looks like.
So we did a RAO.
But most importantly, when you've got that OCT, I'd be very surprised if we see anything concerning on the angiogram.
Right.
Of course, the final angiogram is done without the wire, so rarely the wire will stent up a dissection or something. But
no final, always low mag without wire.
Right. I think that
and
looks
look into
brilliant.
the branches, everything looks good. Then
I think that looks absolutely brilliant. Do you want one final eleocranial just to see the distal portion of the diagonal stent? I always like orthogonal, final orthogonal views.
So this is the one.
Yeah, there you see that pretty well in that one.
So this
view.
this was our working view.
Yeah.
And looks very good. So that little bend in the diagonal was always there.
Exactly.
We just did the ostial lesion.
That was there at the beginning. And the ostium looks beautiful. The OCT looks beautiful. So I think this is a great result.
So I would say the highlight of this case, basically, of course, besides doing the bifurcation, the importance of imaging, because some question about little haziness distally, slight dissection proximally, clearly said that more than 2 millimeter or more than 180 degree dissection, which required 2 additional stents. So these are the cases, something additional need to be done. You can say, well, patient will be all right, even if patient is taking prasugrel. Patient is on potent P2Y12 inhibitor, but can still have a trouble. But by putting the stent and then reconfirming with the OCT that there is no longer dissection left, stent fully expanded, it's a very reasonable approach now. And from interventional point of view, it's okay to complete the case now. And this is the long sheath, 7 French. Patient will get a perclose. Because of bifurcation stent, those patients are monitored overnight. When we use 2 stent technique or rotational atherectomy or any atherectomy, those patients are monitored. Elective cases are appropriate for in-hospital monitoring overnight. And then if things are okay, then discharge next day.
I think the other thing about the imaging is you look right now at the distal stent. You say, okay, is there a little something there at the distal stent edge? But the imaging shows absolutely not.
That's right.
And so you're done. You don't have to worry about that anymore. And the other thing that was so interesting was the difficulty crossing the side branch, recrossing the side branch. And you saw multiple different approaches to do that with an anchor balloon technique, ultimately going down to smaller and smaller compliant balloons. You could use a guide catheter extension, et cetera, and then gradually working your way up to do that final kiss. The pot, very important. So this was really a masterclass, actually, in many ways. This was patient started with triple vessel disease and now is completely ischemically revascularized and should be quite safe to undergo his surgery. And I think his angina will also be relieved.
Yeah, and the question will come that when do we clear him? And it was more of an elective, not urgent. So we minimally waiting 3 months. I know some people may say, well, 1 month or so, some say 6 months, but still 3 months. And in the end, we always put together that what was done for this case in terms of the contrast. It was 150 cc's. Fluoro time was 22 minutes and 50 seconds. Air karma 1.2 and DAP of 89.7. So air karma we follow. And if it is more than 7 or 14, they get regular check or basically warning, tell the patient that, watch for the erythema and so. But if it's more than 15, at 1 month, we make an appointment with the dermatologist.
To look at this, particularly at the back.
In the back. So that's the routine, the protocol which we have instilled at Mount Sinai.
Yeah. So congratulations. I think this was a terrific test Medflix case, and we hope that everybody learned something from this, as did we. Thank you, everybody.
Done. Thank you.
So there you have it. We've done, I think, a lovely instructional simulation of how Medflix cases are going to look like. I want to first of all thank Dr. Kinney, Dr. Sharma, and most of all Dr. Stone for demonstrating what exactly is the purpose of the third operator. And for the viewers for whom we have, it's not the viewers, our sites, for whom we made this video, here are some thoughts for you. First of all, this is just our recommendation. It doesn't mean that you have to exactly do like this, but I hope that you have witnessed the interaction, the smooth flow. It actually unburdens the primary and the secondary operators. They can now just focus on the case, and the third operator keeps the flow going on. We also demonstrated to you how the simulated, the questions will come. Of course, this I don't think will be the final format. I think I'll of course be getting Dr. Stone's feedback, and we'll share his thoughts with all of you in a Zoom session, which we'll do very soon. But I want to get his feedback, and I think one of the changes we'll make is that the questions for the third operator will be coming on a screen right next to the hemodynamics. But I think this should be the way a flow should be. Now, this was a straightforward case in which we did some variations. I don't know if you noticed that Dr. Kinney, in the middle of the case, she had excused herself for an emergency in another room. These kind of situations will happen. But the case we noticed was around 45 minutes. You'll have the second room, I think, the second case around, you have to kind of play around. You have a feeling that about in 5 or 10 minutes you're going to be finished in the case, and somebody else has gone and started the other case. In this particular case, I think, like how Dr. Kinney left, if it is going to be the same team of the first and the second operator, no problem. Somebody leaves, goes to the other room. So the format would be like this, that we would start with the introduction. The third operator picks up from there, and the case is like this. You can make it whichever configuration you want. But the rough, I think, the position, how they are standing, how they are facing the cameras is exactly right. And after the case is done, one of the, I thought, the best most instructional part of this case was that at the end of the case, Dr. Sharma and Dr. Stone are kind of reviewing it. What was the teaching tips? What were the lessons? What are some of the things? The follow-up of the patient. You want to give a very comprehensive end to it. And then the introduction will come all over again. And we'll be putting in some highlight that now we are taking you to the next room or something. So I hope this format has been useful, and again, this will be sent over to you very soon so that you are able to view it many times, and again, we'll discuss about this in a live Zoom session. With that note, I'm going to end the transmission here, and we'll be in touch, and thank you for joining Medflix Live.